For test one, it has got two sections. Section A, which are the multiple choice questions, and then section B are the matching questions. Start from there. Which sympatholytic medication is known for its use in heart failure? Now, as we always do, just to freshen up our minds, when we are talking about drugs that act on the central nervous system, we can split them into those drugs that affect the sympathetic and those drugs that affect the parasympathetic. If we come to let's start simple with the sympathetic. So those drugs which work in the sympathetic nervous system, home, the neurotransmitters which are major neurotransmitters produced is the norepinephrine and the epinephrine itself, or noradrenaline and adrenaline. So the sympathetic is also known as adrenergic system because of the hormones. And so we are going to have drugs that behave like the adrenaline sympathetic nervous system. We have got drugs behaving like adrenaline or no adrenaline, and we call those as the sympathomimetics because they are mimicking, they are behaving like sympathetic nervous system neurotransmitter. And then you have got those drugs that are going to be stopping the action of noradrenaline. So they are breaking the action. So those are sympatholytics because they are breaking to lyse is to break. And for these drugs, we know that the sympathetic nervous system is fight or flight. So when you are running, you're supposed to have your eyes wide open, so they are going to cause mydriasis, or the opening of the widening of the pupil. When you're running, you don't want to go to the toilet, so they are going to cause constipation. So such actions. Then the sympatholytics are stopping those actions. So they want to make you go to the toilet, so that to be diarrhea, vomiting, those things, and then they will make the pupil small. So these drugs, like the sympatholytics, these are blocking the action of noradrenaline and adrenaline. You can divide them into alpha antagonists and beta antagonists. For the alpha, you have got alpha 1, alpha 2, the beta, have got beta 1, beta 2, depending with which location. Now, specifically, we are talking about drugs that we're using in heart failure. So, what is the problem in heart failure? The heart isn't working well. And you know, the sympathetic nervous system, because you are running, is going to be beating very fast. And since you have got one heart, on the heart you have got beta 1 receptors. Since you have got two lungs, you are going to have beta 2 on the lungs, right? Yes, doc. Is is that a hand? Okay. So as we are saying, since we have got one heart, we have got beta 1 receptors there. Now, beta 1 receptor stimulates the heart because remember this is sympathetic. The heart will be beating so fast and it will be contracting very fast. So in heart failure, you don't want that. You don't want the heart is failing. The heart is not able to do those things, and then you are forcing it to do it even all the more. So drugs that you use on the heart are the beta blockers, the alpha, especially the beta blockers, or the best is actually beta and alpha blockers. These ones which are non-selective because it will also be affecting the alpha receptors. If it affects alpha receptors, like alpha 1 is present on the blood vessels, you dilate the blood vessel. So blood will be the heart. is failing, right? You have given a drug that is inhibiting, that is stopping the heart from much contraction, but that drug at the same time is making the blood vessels to become big, such that the capacity to which the heart is able to pump, it can as well allow that blood to pass in the blood vessel, because the blood vessels are at least big. We know what happens when you have got a hose pipe that is big, and then you have got, let's say the tank has got little water, or the pump is not pumping very fast. That is going to help. So that is an overview. Now, since we've already mentioned this, it is a good introduction. All the questions to do with beta blockers and alpha blockers will not talk about anything, since we've refreshed our memories. So let's now answer the question: which sympatholytic medication? Here now you just want to be specific. We already know that the drugs that you can use in heart failure are those beta blocker drugs. But then to be specific, which one is the most recommended? You can see we have got propranolol, which is both beta 1 and beta 2, metoprolol, which is the selective beta 1, atenolol, which is the cardioselective beta 1 blocker also, and then Carvedilo, which is beta and alpha blocker. Which one can we pick? Anyone? Thank you so much, Carvedilo. So this one we just need to know it is the drug of choice in heart failure. Although it is working on the same receptors that other drugs are also working on, but it's a drug of choice. Question number two: a male patient who developed a severe unexpected adverse drug reaction to a drug they had never received before, despite receiving a small dose. Which of the following factors is most likely the cause of this very rare event? Yes, please. Okay, why can't we go for B? Why can't we choose metoprolol? Anyone that can help? Anyone that can help with that? Hmm. Okay, that is what, that is one. Yes, Doc, you can go on. Thank you. That's the thing. Thank you so much. Doc, is that okay? Thank you. So Cavedilo has got an effect. It is reducing the contractility of the heart, because the heart is failing. At the same time, you are making the blood vessels to become big. So that, remember, when you are running, you want a lot of blood to move around. So sympathetic nervous system will be able to dilate these blood vessels. And specifically, Cavedilo is both a beta and alpha blocker. These others are only, you can see they're only working at beta receptor. Okay, question number two. A male patient with may develop severe unexpected drug reaction to a drug they had never received before, despite receiving a small test dose. Which of the following factors is most likely the cause of this very rare event? Now, this is coming from factors that modify drug effect. There are quite a lot of questions in here, so let me just mention something about it within a minute. On factors that modify drug effect. You know, a drug is supposed to work normally, but then because of some things, it will not work as you expect. So some one factor that can affect or modify the effect of a drug is physiology. So you have got physiological factors, and physiology, we know that these are normal things. So what are some of the physiological factors that can affect drug effect? Anyone that can mention one? There is sex, thank you. Also age. Anything else? These things are physiological. Being male is not a sickness, and me being 20 is not a sickness. So there is also genetics, and there is also ethnicity, where I come from. Another important thing is pregnancy. So these are going to affect the way drugs are going to work because of different biological compositions, the age, and such. So specifically, body weight, age, sex, and pregnancy. These guys are going to be affecting an individual. So age, I'll put I there. Body weight, although body weight is both. I've not even put weight here. Sex. So there's also weight. Weight can also affect like one individual, like how fat someone is or how small someone is, will affect how a drug will be able to work in them. You can as well compare that person with others. So it's both individual and interperson. Okay, besides the physiology, you can also have pathological conditions, and besides pathology affecting the way a drug is going to work, you can as well also have the dose, drug dose. I'll put D, drug dose. And the drug dose will include things like the route of administration and the interactions of that drug. We know for drugs that are metabolized in the liver, they're going to be affected by liver enzyme inducers and inhibitors, things like rifampicin, antifungals like ketoconazole. So besides that, we also have psychological factors. Psychology, it has to do with the mind. So, for example, painkillers are more effective in pain conditions. And also, just the relationship that a patient has with the doctor can make them respond to a drug. For example, a patient has got a good relationship with a doctor. Just that. If the doctor says, go and get this drug and drink, not because the drug is even effective itself, but because of much belief. So, psychological, it's including that. Also, the diet and the environment also affect the drug effect in our bodies. There will be food interactions and such things. For example, chili will increase intestinal absorption and then be able to cleanse the nose. So just that, when you are eating and then you also take chili, it will increase absorption. It can also help to cleanse the nose. The environment, remember, it's that and environment. The environment, things like pollutants also affect. So those are the things. Now here we already know. Back to the question, all the questions that has to do with the factors that modify drug effect, will now be just answering them direct. So here we have got an expected adverse drug effect. What interaction is that? Age, disease state, idiosyncratic reaction, psychological factors. So when we look at the psychological factors, there's also one thing that I didn't mention: the idiosyncratic reaction. That is where you have got an effect that you didn't expect for that drug. Like you take a drug at normal dose, the dose that everyone is supposed to respond. But then when you take it, you have got some other adverse reactions which are unexpected. So which one can we pick now? Anyone? C. Thank you so much. So that is it. Number three, methylxanthine, for example, theophylline was the first line reliever in managing asthma before beta 2 agonists. Now it is a second line asthma reliever. What is the best reason for the demotion of the in the management of asthma? So number eight, theophylline is an antagonist. Or let me not even read the options. We have got a lot of questions on asthma in this paper. So let's talk about asthma also under a minute, and then the rest of the questions will be able to answer them. Now, number one thing that we need to know is that asthma, the problem is this. Here, let's say, is our normal respiratory tract. But then some changes start to happen. This respiratory system, three things can happen. Number one, it can be just constricted. So there is broncho constriction. Number two, there can be accumulation of mucus. Number three, there can be edema, broncho or edema. So what you are going to see is that the edema or the mucus is going to come like that. Look at what has happened. The entry to the alveolar has become small, and so, because of that, you can't take in oxygen, neither can you remove carbon dioxide. And the biggest problem here is that you cannot remove carbon dioxide. That's the biggest problem rather than you taking in the oxygen. So, what is going to happen is this: the air that is in the alveolar is failing to go out. So what happens? The alveolar is because it has got already air, and then oxygen at least is entering more than carbon dioxide is leaving. The meaning of that is that the alveolar is remaining that much dilated, and that is known as hyperinflation. So, what will be the result of that? A patient is having difficulties in breathing because when they are trying to breathe in, there is no space for you to take in more air because it's already full. Hyperinflation. But then, what is the problem in this condition? The problem is the major one. There is bronchoconstriction. And what is the cause of that? The cause of this bronchoconstriction can be a lot of things. Number one, remember when you're talking about we have got our membrane phospholipids. Membrane phospholipids can be converted to uh, arachidonic acid. Arachidonic acid. This arachidonic acid can be converted to, it can go into two pathways. Number one pathway is you forming the prostaglandins. Number two pathway is you forming leukotrienes. For it to form prostaglandins, you need the COX enzyme, cyclooxygenase. For it to form leukotriene from the same arachidonic acid, you need uh, LOX. This is the leucooxygenase. Like you are forming the leukotrienes there, and then you are forming you have got COX. So these are the two. So what happens is that if you give drugs, for example, aspirin, you know that aspirin is a COX inhibitor. Now, these prostaglandins are important in that, like the prostaglandin this side, they help in platelet aggregation. Okay, so you can give them in inflammation so that some those platelets can come together, and then they can as well help in pain relief. They can help in fever. They can help in vasoconstriction. But then, when you're trying to treat all those conditions with NSAs, non-steroid anti-inflammatory drugs, and also including the aspirin, of course, paracetamol can also be used here, but paracetamol is a COX-3 inhibitor, a bit different from this mechanism where we've got COX-1 and COX-2. So what is happening is that when you give aspirin, you are inhibiting this enzyme. Arachidonic acid is going to take another pathway. It is going to start now making more of the leukotrienes. And these leukotrienes, the problem is that they cause bronchoconstriction. So that is a problem with taking. That's why you don't take aspirin when you have got asthma. Another problem is this: someone is allergic. I can be allergic to drugs or allergic to anything. And you know what happens when someone is allergic? When they inhale that allergen, the immune system is going to be sensitized. The second time they inhale that allergen, what is going to happen is that the mast cells are going to degranulate. When they degranulate, they are releasing the leukotrienes, they are releasing histamines, and those things are furthermore going to cause constriction to the alveolar. And so, when you want to manage someone that has got asthma, these are the basic things that you are trying to work on, that you are trying to help in. So, let's talk about just that. Remember, we have said we have got two pathways here. We are going using COX forming prostaglandins and then forming leukotrienes. Leukotrienes. So the drugs that we give for someone that is asthmatic, we can divide them into three groups. Number one, we have got bronchodilators. Remember, the problem is that there is constriction. And then number two, we can give anti-inflammatory agents. Anti-inflammatory. And then number three, we can give those guys which will be working on leukotrienes. So on the guys that are working on bronchodilation, the major ones that we have got beta blockers, actually beta agonists. Remember the sympathetic nervous system, as we said, sympathetic is you are running, right? When you are running, you need more air to go into your central nervous system. So specifically, we said that the lungs, we have got two lungs, so beta 2. So these are agonists because the sympathetic makes the bronchos to the walls to be dilated. You can as well give M3 antagonists. These are antimuscarinics. You know that acetylcholine is a major neurotransmitter in the parasympathetic. Parasympathetic, you are resting. So what happens normally is that the airway also becomes small because you don't need a lot of air. But then you have got asthma here. So give antagonists. They are fighting that small airway. And specifically, it's the M3 found in this respiratory system. On the anti-inflammatory drugs, you can give corticosteroids, and then you can give those drugs that are going to be working on the mast cells so that they don't degranulate. So you call them mast cell stabilizers. They are also known as histamine release inhibitors because remember the mast cells release histamine, and that histamine is causing constriction. And then you also have other drugs that will help in inflammation are monoclonal antibodies against IgE. Because the problem is, remember we talked about sensitizing first the mast cells. Who does that work? So we have actually the antibodies coming in, specifically IgE coming from your IgE when it is sensitized because of the allergen is the one that is producing antibodies, and that antibodies are trying now to fight back. And these same antibodies are the ones activating other systems so that they come to help fight the infection. So you want to give antibodies against these antibodies. That's what we are calling monoclonal antibodies. And then for the leukotrienes, you have got two. You have got LOXY inhibitors. Remember, we said we have got LOX here. This enzyme. This enzyme is causing the production of leukotrienes, isn't it? And these leukotrienes, we said that they are causing bronchoconstriction. So inhibit the enzyme producing them. Those are LOX inhibitors. And then number two, we also have the leukotriene receptor antagonist. In case leukotrienes are already produced, you want to go on the respiratory system where the leukotriene is supposed to go and bind to cause constriction. You are giving a drug that should bind there so that the constriction doesn't happen. So those are antagonists. Okay. So, real quick, what we should know about these drugs is starting with the beta blockers. The beta blockers, you have got those which are short acting and those which are fast acting. Please take note of this. For the short acting beta blockers, they are the first guys that you give. Whether someone has come with a chronic condition or it is acute, you give short acting beta blockers because they are going to be real quick in helping in symptomatic relief. Like they work in 4 to 6 minutes. They are real quick. So whether the condition has been chronic or it is moderate, mild, please first give the short acting beta 2 agonists. Okay. So for the you also have the long guys, but again, just for the short acting beta 2 agonists, you also need to know that when you use them regularly, they are going to cause a transient hypokalemia. This is just happening, it's not forever. Transient, it comes called hypokalemia, and this hypokalemia you are going to see it with muscle cramps. That is when you use the short acting beta 2 agonists regularly. And when you use them in excess, they are going to start causing CVS effects and things like tachycardia. From this, you should understand one thing: beta 2 guys work on the bronchioles, but why are they causing tachycardia? Because on the heart, you have got beta 1 receptors. It doesn't mean that when a drug is beta 2, it can't work on other receptors. It's just that it's working more on the beta 2, but it can as well stimulate the beta 1 receptors. That's why it can cause tachycardia when you get to use it in excess. For the long acting guys, one thing you need to know is that you never use them alone. Instead, you are going to give them with the inhalational corticosteroids, those corticosteroids that you are going to be breathing in. Okay, please take note of that. That is very, very important. You are going to say things like salmetero, formetero. So those guys, the long acting, they have got a long half life. That's a good thing. And what you do is that these guys, you can give a metered dose in. You give them. They are actually found in an inhaler. All right. Please take note. All beta blockers are going to be found in the inhaler. That's the mode in which you give them. You can as well give them in a nebulizer. You can find them in a nebulizer, but that is in emergency situations. Glucocorticoids, on the other hand, you need to take note of this. Again, just one thing about beta blockers, the long acting, is that they also, besides them, these are beta blockers, right? They can as well reduce the degranulation of the mast cells. The same beta blockers which are long acting. So never use them for acute attacks, the long acting, because they take long to act. You use the short one. So never use them for acute attacks and never use them as monotherapy. And these guys, they can show close tolerance. On the short acting, we have got a drug known as albuterol. Albuterol is a short acting beta 2 agonist. So these long acting can as well interact with it. But albuterol, besides you giving it in an inhaler or nebulizer, it can as well be given orally. That's one thing you need to take note. And besides the beta blockers, you giving them like the short acting, you giving them in a nebulizer. You have tebutalin, which you can give subcutaneously, and that is in emergency situations. Please take note. This is just telling you that beta blockers, they've got a lot of ways in which you can give them. That's why they are good. Okay. So take note of that. Beta blockers can as well inhibit tremors, tachycardias, and cough. Now, on the glucocorticoids, the most important thing one important thing you need to know about them is that what are glucocorticoids? These guys are preventing inflammation. So you are basically using them before the condition worsens. That is for prophylaxis. Because what is going to lead to you even having, like, for you to have the constriction, it means that there was maybe some form of infection and that caused the allergen to be seen by the nervous system, and then you are trying to attack it. That's why the constriction came in. So the glucocorticoids are used for prophylaxis. So it's useless to give them in acute event because, like, constriction has already happened and these guys are used to prevent what was supposed to cause the condition. And glucocorticoids, you also give them in a nebulizer or inhaler. So I've got those which are given inhalationally, and then you have got some which you can give IV. Please take note, IV and inhalation. Specifically for IV, you are giving them in emergency situations for acute episodes. Emergency. I've said that glucocorticoids are used for prophylaxis. But besides the prophylaxis, in emergency situations for acute episodes, you can give them, and that is IV. The only adverse effects that these guys have is that they can cause oral candidiasis. They can as well increase the calcium loss from the bone. Okay, they can as well suppress the hypothalamic pituitary adrenal axis. Take note of that, but so that is there. And then the anticholinergic drugs, those guys, what you need to know for them is that they inhibit bronchoconstriction. So I've got one important guy there, ipratropine. That guy, it is an anticholinergic, and for that one, it is a it has got bronchodilator activity. When you give it together with a short-acting beta 2 agonist, is going to help in bronchodilation also. Okay, when you, especially when you give it to the short acting, the albuterol which we mentioned in severe acute cases. So take note of that. And then for the leukotrienes, these guys, as we said, you can see, you can give those which are inhibiting the enzyme, as we said, the LOX enzyme, which is here, and the only problem, so for the guys that are inhibiting, please this one is important. For the guys inhibiting this enzyme, you don't prefer giving them than to the one that to act as an antagonist for leukotriene on the receptor. Why? Because these guys cause liver toxicity. Specifically, you have got one drug which is known as Zilenton, Ziluton, however you pronounce it. We are going to see it in the question. So this guy is bad because it causes liver toxicity. Please take note of that. And so when you give it, you're supposed to be monitoring the liver enzymes. And then you have got another drug which we call the methylxanthines. An example is the theophylline, which is given also here. This is a second line drug in asthma. What methylxanthines do is that, remember, in this mechanism, you are going to get it like in bronchoconstriction or dilatation. You get ATP, you are going to convert it to CMP. That is adenylate cyclase doing that. But then when you have already done the work, because CMP is very good, it actually causes the constriction. I mean the dilatation of the bronchioles. But then the problem is that CMP can be broken down, and when it's broken down, there's no bronchodilation anymore. And who breaks that is phosphodiesterase. So methylxanthines are coming to inhibit phosphodiesterase from breaking down CMP, and so you're going to maintain your lungs to be dilated. The only problem is that this guy is expensive, right? Besides that, the methylxanthines, specifically theophylline, is also good in that it inhibits adenosine. Adenosine causes constriction, and it will inhibit this guy. Adenosine is used in the treatment of tachycardia, but it's bad for asthma. While theophylline is used for the treatment of asthma, but is bad for tachycardia. So please just get that. Okay. I think that's the basic thing. How do you give methylxanthine? You are going to give it either orally or suppository. Like, imagine those some of you have got some drugs which you can insert like in the body. For example, taking them through the anus or things like that. So that's another method in which you can use this, and then you can as well give them more parenterally, like via IV. This is just telling you that methylxanthines are good because you can use them in with different they have got different routes. Only problems are they're expensive. You also have this class of drugs which are known as chromons. So the chromons, these guys, they are given inhalationally, and they are also used for prophylaxis in mild to moderate cases. The mechanism of action is that these guys are going to inhibit the release of histamine from mast cells. Another thing is that they can suppress the activation of the white blood cells, which lead, the B cells are also part of the white blood cells, right? So they're going to suppress the activation of the white blood cells. Besides that, they also inhibit chloride channels that lead to production of mucus. Remember, we said another problem in this condition is that mucus is a lot, and that causes the lumen to become small. And then the IgE monoclonal antibodies. And take note that the hormones, they are also used in exercise induced asthma. When you are running so much and then you are running out of breath, the antibodies you give them subcut alone, subcut, no any other method. So for these guys, you can use them in those conditions that are stimulated by allergy. Remember, we said that allergies cause the activation of the antibodies. So you can't give them in other conditions because some other causes don't involve antibodies. All right. So you give them in allergy exacerbated asthma. And the example that you are going to give, these guys end in Zumab. So when you just see a drug with Zumab by the end, you know that it's an antibody. And this drug, you give it to people that are greater than 12 years and they've got moderate to persistent asthma. And specifically, you need to do a certain test. And when that test shows that indeed someone has got antibodies, that's when you are going to give this drug. Okay. So we've talked about everything to do with asthma. So now we can answer all the questions to do with asthma. So now we're talking about methylxanthines here. So the bigger reason wasn't because of the narrow therapeutic index, it's because of it being expensive. I hope you get that. All right, welcome. Okay, question number 4. A 24-year-old man with mild persistent asthma has poor response to short-acting beta 2 agonists. Please, I didn't mention this. When you have got a drug that fails, beta 2 guys. Anyway, let's first go on. Short-acting beta 2 agonist and complains. Remember, there is poor response and is complaining of tachycardia. You know the reason, right? And severe tremors, even with inhaled drugs. Which are the following alternatives can you prescribe to relieve the acute exacerbation of asthma? Long-acting beta-2, glucocorticoids, acetylcholine muscarinic antagonists like ipratropium bromide, theophylline, which is a methylxanthine. Anyone to help with this one? Acetylcholine? Or do you masculine antagonist? Or do you help why you think so? Yes, please. Okay. Is there anyone that wants to give it a try? Yes, Doc. Anyone who wants to give it a try, please be free. Okay. Thank you so much. And one of the biggest reasons as to why we are going with acetylcholine muscarinic antagonist is that here there is poor response to the beta guys, and this one is short acting. Remember, the short acting is what comes to help the patient. Like in every situation, you first give the short acting guys before you can go to any other drug because they are going to help with the symptoms and then. But then the short acting beta 2 agonists are failing. This means that even when you give the long acting, they are still working the same. It's just that one is short, one is long. So what you want to do is, because these are bronchodilators, give another alternative bronchodilator, and the alternative bronchodilator is the acetylcholine muscarinic antagonist. Hope we get that. A 55-year-old woman has an acute exacerbation of asthma symptoms every other month. She is not on any medication, take note, of for asthma. What is the severity and management of asthma in this patient? Okay, as an acute exacerbation of asthma symptoms every, take note, every other month. So what is the severity and management? A. Mild intermittent asthma prescribed an inhaled short-acting beta-2 agonist and controller drug as needed. B. Mild intermittent asthma prescribed an inhaler short-acting beta-2 agonist daily. C. Mild intermittent asthma prescribed an inhaled long-acting beta-2 agonist as needed. D. Mild intermittent asthma prescribed an inhaled short-acting beta-2 agonist as needed. Anyone that can help with this one? Let me just mention something. When you are classifying asthma, so you have got mild intermittent condition and you have got the frequent one. So if it is mild intermittent, it is happening less than twice per week. Less than twice per week. And then you are going to say asthma is frequent when it is exacerbating, it's worsening every 1 to 2 months. Every 1 to 2 months is worsening. If you have got less than 2 times of the asthmatic attacks per week, that is mild intermittent. Hope we get that right. So which one can we say? You can see there is acute from the condition acute exacerbation of asthma symptoms every other month. This is every other month, not every 1 to 2 months. Anyone that can help? Mild intermittent asthma, and you prescribe. Thank you so much. That's mild intermittent, and then you are going to prescribe uh, inhaled short acting. Remember, for whatsoever condition, prescribed inhaled short acting as needed. You don't do it daily. It's the short acting you prescribe them when the condition is there because it's helping for short acting. Okay, which of the following sympathomimetics is primarily used as a bronchodilator in asthma and COPD? I thought I didn't mention them, but I did. Terbutaline, isoprotren, isoproterenol. Hey, anyone who read that to read. C. Phenylephrine. D. Norepinephrine. Anyone who can pick an option there? A beta 2 adrenergic agonist. Thank you so much. And we did mention, remember, terbutaline, and we said that it's actually a short acting guy and it can as well be used. We said besides these guys being used in the inhaler, terbutaline, to be specific, has got another mode through which it can be given. What mode is that? Anyone who got that? Thank you so much. Subcat, yes. Okay. Number 7. Please don't forget, how about our butero? Which other mode can you give it besides the inhaled method? IV? Okay, that one is oral. A 24-year-old man with mild persistent asthma has poor response to short. Oh, we have already answered this. It was repeated. All the following agents act by intracellular receptor except vitamin D, thyroid hormone, insulin, steroid hormone. Anyone that can help with this guy? Which one doesn't act by intracellular receptors? Thank you so much. Insulin. So just something short. Here is our cell membrane. There's a receptor there. And then here we have got the cytoplasm, whether in the nucleus or just in the cytoplasm, we have got a receptor there. So drugs that are hydrophobic, remember the cell membrane is made up of lipid. So drugs that are lipid in nature, drugs that are lipid in nature are going to cross the cell membrane and they are going to act inside the cell. Vitamin D is a lipid soluble vitamin. Thyroid hormones are lipid soluble. Steroid hormones, these are lipids. So they all go into the cytoplasm. Insulin is not. So it will bind to this receptor here. Okay, so the answer is insulin. Number 9, a child with severe malnutrition has low albumin and serum protein. Take note, low albumin and serum proteins, which would reduce serum binding. What variation in drug response would you expect in this scenario? Liver disease resulting? Yes, please. Uh, for this one, okay. So question. So we skipped question 7 because we had already answered it. Question 8, we've said it's insulin, and then now we are now question 9. Okay. So that one we picked D. Is mild intermittent asthma prescribed? Okay. 9. A child with severe malnutrition has low albumin and serum proteins, which would reduce serum binding. What variation in drug response would you expect in this scenario? Liver disease resulting in a reduced rate of drug metabolism, less drug efficacy due to conformational changes in the target site, less adverse drug effect because only the protein bound drug is active at the target site, reduced duration of action of the drug due to increased excretion of free drug molecule. Anyone that can help? Thank you so much, Doc. Very concise and direct. You have got if you have got a blood vessel, here is your albumin. If you have got more albumin, more of the drugs are going to bind to albumin. But if you will have less albumin, more of the drugs are going to be free. And because they are free, they are going to have more chance of going to excretion. And so there is a reduced duration of action because they're being excreted. Number 10, which of the following statements best describes the importance of understanding the cause of individual variation in drug response? Why should I understand why a certain drug can work in me and not in the other person? Or the variation in differences in how drugs work? Number A, same drug dose only causes different degrees of response in different patients. They may cause serious problems such as lack of drug efficacy or unexpressed adverse drug effect. C. Only pharmacokinetic variations lead to differences in drug response. D. Pharmacodynamic variations are the only cause of drug response variation in the individuals. Anyone that can help with this one? Anyone? Which of the following best describes the importance of understanding the cause of individual variation in drug response? Okay, so you want to understand the cause of individual variation in drug response for one important reason. You want to optimize the dose to individual need. See, let's say for example, you have got a person A and a person B. You want to understand their individual variations to how they're going to respond to each drug, because this, depending on each one of their needs, you can reduce the drug dosage so that the person doesn't get a lot of adverse effects. For some, you can increase it, maybe depending on their body mass, weight, age. And the main thing is that you want the drug to be effective for the person, and number two, you want to minimize side effect. Those are the two main things. Okay. So the best option you can go for there is B. They may cause serious problems such as lack of drug efficacy. Lack of drug efficacy just means that the drug is not working as expected, and also unexpected adverse effect. Remember, we've talked about two things. Want to understand the difference so that you ensure that the drug can work and you minimize side effects. Hope that is okay. Number 11. The fastest acting receptor or transduction mechanism is intrinsic ion channel operation, nuclear receptor adenylyl cyclase cyclic AMP pathway, phospholipase C IP3 DAG pathway. Anyone that can help with this one? Pardon? Oh, thank you so much. Ion channels are the fastest. Number 12, an elderly patient is prescribed vitamin D to improve their bone density. They also have gallbladder disease. Remember, from the gallbladder, you have got bile acids which help in digestion of fat. So, since they have got this gallbladder disease, they can't digest fat, and that leads to steatorrhea. Fat is 2. He has normal kidney function. 12 months later, the patient showed no improvement in bone density despite being compliant. Like, you are giving them vitamin D. After 1 year, there is no improvement in the condition, even when someone is compliant. What is the most likely reason for the lack of drug response? Liver function decline with age, so drug metabolism is reduced. Renal dysfunction due to age affects drug excretion. C. The patient factor causing resistance to vitamin D. D. Malabsorption disorder, so drugs are poorly absorbed. Anyone that can help? Anyone? Thank you so much. It's malabsorption. Remember, vitamin D is a lipid soluble vitamin. So already, if you don't have, like, your gallbladder is not working, you can't produce bile that helps in absorption for vitamins. Okay, and so that affects everything. Actually, gallbladder produces bile acids, which helps first in digestion. So you can't digest the lipids, including the fat soluble vitamins. So there's malabsorption. Number 13. Increasing or repeated drug dose may cause the following drug responses, except which of the following? Increasing or repeated drug dose is going to cause the following, except A. Tolerance, which is the requirement of higher doses of a drug to produce a given response. B. Increases magnitude of response till the maximum effect plateau, like it goes like that. C. Continuous increase in response magnitude as long as the drug is taken. D. Opposite effect to therapeutic drug effect. Anyone that can help? C. Thank you so much. So what happens that when you take a drug for long, you can be tolerant. You need a higher dose. Number two, it can increase magnitude of response till the maximum effect. Like, when you increase the dosage, you are going to have a more effect. You increase more effect, but you reach a point where you, even when you increase the dosage, nothing is happening. Instead, it will be becoming worse. Sometimes can produce the opposite therapeutic effect. You are taking an antagonist, it starts acting like an agonist. Okay, number 14. Leukotrienes cause bronchoconstriction and overproduction of airway mucus. Lipooxygenase inhibitor like Zoloton and leukotriene 1 receptor antagonist, which is Lucast, are equally effective. This is one thing you need to know about those guys we mentioned. Those which are inhibiting the receptor for the leukotrienes and those which were stopping the production of the leukotrienes, they have got the same effect. Okay, so are equally effective in mild to moderate persistent asthma. What is the reason that Zoloton is less prescribed than Lucast? A. The Lucast have mild bronchodilator activity. B. Lucast are more effective than Zoloton because they block the leukotriene receptor. C. Zoloton is available as an oral formulation and the Lucas are available as inhalers. D. Zoloton is associated with liver toxicity, resulting in poorer side effect profile despite equal effectiveness. Anyone that I can help here? Thank you so much. It's because of liver toxicity for the inhibitor of lipoxygenase. Which sympathomimetic medication is used to treat attention deficit hyperactive disorder and narcolepsy? Where someone is too sleepy, sleeping in the day, by increasing the release of norepinephrine and dopamine. Dobutamine, ephedrine, methylphenidate, or butyrol. Anyone that can help? Okay, see, methylphenidate. Anyone with a different option? Okay, so remember this guy is a stimulant. So phenidate, how it works is that it's going to, you know how it, when while we're discussing the insomnia and the anxiety, the thing there, there are some neurotransmitters that are decreased. So methylphenidate increases dopamine and norepinephrine. What it does is that it blocks the reuptake of these two neurotransmitters, and you know their importance in attention, in activity, and in sleep. That is why it is the one that we are using. These other guys are adrenergic receptor drugs. 16. In chronic liver disease and chronic renal failure, drug distribution is affected due to altered plasma protein binding. Which of the following factors would cause the variation in drug response? Remember, we have got what? Chronic, both renal failure and liver disease. Okay. So, which of the following factors would cause variation in drug response? Pharmacokinetic variation, different response to the same drug concentration at the target. B. Pharmacodynamic variation, different concentration of the drug reach the target site. C. Pharmacodynamic variation, different response to the same drug concentration at the target site. Number D. Pharmacokinetic variation, different concentration of the drug reach the target site. Anyone that can help with this guy? Okay, would you help explaining? Mm, okay. You said which one is the option that you picked? B. Okay, thank you. D. Okay. Anyone with another option? Are we all in for D? Or maybe there's another one with another option. Anyone? Let's analyze the question again. Here we have got chronic liver disease and chronic renal failure. We know that when the liver is not working well, the kidney is not working well, we are affecting metabolism. Metabolism more for the liver, and then we are also affecting excretion for the kidney. So we're affecting these two guys. So if we are affecting metabolism and excretion, it means that we have affected the concentration of the drug, right? Concentration. Because if the liver is not working, let's say maybe for example, this drug was supposed to be activated in the liver, to not be activated, so we're going to have little concentration that is effective. If maybe this is broken, this enzyme is broken in the liver to make it inactive, then that still has disturbed the concentration, isn't it? And as we've said, drug distribution is affected due to altered plasma protein binding. Which of the following factors will cause the variation in drug response? So here, since we have got this change in concentration, what do we expect to see now at the end of, not really at the end of it all, but this metabolism and excretion itself, what properties are this? Is this pharmacokinetics or pharmacodynamics? So as our doc has said, that's pharmacokinetics, isn't it? Just think of kinetic has to do with the motion. Excretion is motion, metabolism, absorption, and those things. Okay, question 17. Which statements apply to long and short acting beta 2 agonist and asthma management? They are selective for beta 2 receptor in the lung, so they never affect beta 1 receptor, primarily in the heart. B. Inhaled formulations act locally in the lungs, producing fewer side effects. D. I see they are best treatment for all forms of bronchoasthma, even as monotherapy. D. Short acting beta 2 agonists can be replaced by long acting beta 2 agonists if a patient has more than three acute exhibitions in a week. Anyone to help with this one? Anyone? D. Do you have any thought of why you think it can be B? D? Okay. Okay. Is there anyone also that wants to give it a try? Anyone? Okay. Let's look at this. We are trying to, which statement applies to long and short acting? We can analyze each statement so that we get it properly. A is saying they are selective for beta 2 receptors in the lung, so they never affect beta 1 receptors primarily in the heart. Is that true? Remember, we said that yes. Oh, please go on, Doc. Thank you so much. It can as well have other effect on the other receptors because it's actually the same. They are all receptors for adrenaline anyway. Let's go to D. Short acting beta 2 agonists can be replaced by long acting beta 2 agonists if a patient has more than three acute exacerbations in a week. Is that true? Okay, so when someone is having these acute guys, like someone is having attacks, these attacks, and if you see a lot of attacks per week, it's going to give you one meaning. It is going to tell you you actually need to change and and make give them more a permanent treatment. Let's say for example, someone came with an acute attack today. You gave them the short acting, which is real quick, isn't it? They and again tomorrow they have an attack. You give them the short acting. The other day they have got an attack. You give them a short acting. So when you have got more of those attacks and you are giving them short acting beta agonists, it is telling you that you need to introduce them to a fast to a more prolonged treatment. So you can now introduce them to the long acting beta blockers. Okay. But necessarily not what this statement is meaning there. Short acting B2 agonists can be replaced by long acting agonists if a patient has more than three acute exacerbations in a week. They are best treatment for all forms of bronchoasthma, even as monotherapy. We already said that the long acting, you never use them as monotherapy. Inhaled formulations act locally. That's the that's why we use inhaled guys, because they act locally and that helps to reduce side effects. Those which you use IV, they have got a lot of systemic effects. That's why they are not good. Are we okay for this one? Okay. 18. Which sympathomimetic medication is commonly used as decongestant due to its vasoconstrictive effect on the nasal blood vessels? Do, do, dopamine, alpha 1, alpha 2, beta 1. Dobutamine, beta agonist. Terbutaline, beta 2 agonist. Pseudoephedrine, alpha and beta agonist. Anyone that can help for this one? Anyone? Give it a try. It might be the correct one you are giving. Pseudoephedrine. Why do you think so, Doc? Any thought? None? Okay. So this guy, pseudoephedrine is the answer. It's an alpha and beta agonist. So I'm going to give it because remember the alpha receptor, specifically we can go to alpha 1, even the alpha 2. You are going to find them in blood vessels. Okay, those alpha receptors. So the blood vessels, what they are going to do there, remember which symptom as decongestive due to its vasoconstrictive. So in the blood vessels, they're going to cause vasoconstriction of the nose. And then besides that, you want a drug that will also be working on beta 2, which is present where? In the lungs. So option A doesn't have beta 2, so it's not a best because it's still uh anyway, we're not even talking about the lungs here. They have just asked for symptomatic medication common used as decongestant because of its vasoconstrictive effect, but this is still nasal blood vessels. It's related to the respiratory system. So pseudoephedrine is the best because of its action on the alpha 1 receptor. It causes constriction of the vessel, and that constriction is going to reduce blood flow, and that can as well help in reducing swelling and congestion. So that's why that guy is used. Long-acting beta-2 agonists produce relaxation in airway, smooth muscle, and moderate decrease in the release of mediator from mast cells. Which of the following statement is true about managing asthma using this group of drugs? They're long-acting. Long-acting beta-2 agonists can substitute short-acting agonists to relieve acute symptom asthmatic exacerbation because they have an early onset and longer duration of action. Long acting beta 2 agonists require less frequent dosing in a day than short acting beta 2 agonists because they have longer duration of action. Therefore, they are unlikely to develop tolerance. C. Long acting beta 2 agonists are relievers and controllers because they can lower immune mediators to the same degree as corticosteroids. D. With a frequent systemic use, long-acting beta-2 agonists may cause hyperkalemia and tachycardia because beta-2 selectivity is relative to the dosage reaching other receptors. Anyone that can help with this one? Anyone that can help? Okay. I hope people can get me. Are we able to? Yes, doc. Please, you can go on. Long-acting beta-2 agonists can substitute short-acting to relieve acute asthma exacerbation because they have got. Okay, good. So you can't substitute long for short because for acute symptoms because they actually take longer to start working. So the best option you can pick there is the frequent systemic use. They can cause hyperkalemia, which can be manifested by muscle cramps and tachycardia because selectivity is relative to the dosage. So those side effects that we saw, of course, I mentioned them when I was talking about them on the short acting, but it's still better as long as it's prolonged use. They'll still end up causing these side effects. In pediatrics, most medications are prescribed according to the dose per kg. Dose per kg. Which of the following factors affecting individual variation in drug effect is being overcome with this approach? Age, body weight, disease state, idiosyncratic reaction. Anyone that can help? Body weight. Thank you so much. Remember it's dose per kg. Okay. 21. A child with severe malnutrition has low albumin and serum proteins, which would reduce serum drug binding. What variation in drug response would you expect in this scenario? What variation in drug response would you expect in this scenario? Less drug efficacy due to conformation. Let me just point out to some things. Severe malnutrition. Number one, low albumin. Those are the main things. Less drug efficacy due to conformational change in the target site. Liver disease resulting in reduced liver disease resulting in reduces the rate of drug metabolism. Okay, there's something wrong there. So it was supposed to be liver disease resulting in the reduction of the rate of drug metabolism. C. Increased adverse drug effects due to high amount of drug at target site. D. Less adverse drug effect because only the protein bound drug is active at the target site. Anyone that can help? C. Thank you so much. Remember, you don't have albumin to hold the drug, so you have got more of the drug at the receptor, and that is going to increase the side effects. Number 22, a woman may be treated for nausea and vomiting. She feels more nauseated during certain times of the month, especially during ovulation when she needs a slightly higher dose to feel better. Slightly higher dose. Remember, this woman, it has to do with what? It has to do especially on ovulation. This scenario is an example of the following factors most likely to cause the variation in drug effect in this patient: genetic factors, physiological factors, sex, pathological factors, pregnancy, physiological factors, gender. Anyone that can help? Anyone? Which one are you going to pick? Which option? Why have you picked B? Since we have got another physiological factors, gender. Okay, thank you. Anyone that wants to give it a try? So the difference is just in sex and gender. You know, we have got males that are women. You know, we know that, isn't it? That's gender. But sex, you can't change sex. If you have got a vagina, you are a lady. But we have got some ladies that have got a penis. This is just telling you about gender. So gender itself is not specific. People have decided to change themselves. So it is sex, which is a physiological factor. Because this person can undergo ovulation, obviously you're expecting that the sex, they are female. Hope we've gotten that. I can't say much. Leukotrienes cause bronchoconstriction and overproduction of airway mucus. 5. Lipoxygenase inhibitor, Zolotin, and LT1 receptor antagonist Lucas are as helpful at as low dose glucocorticoids in mild to moderate persistent asthma. Which of the following is true about these drugs? Leukotriene modifiers and glucocorticoids are available in oral, inhaled, and IV formulations. Leukotriene modifiers can help reduce the severity and frequency of acute asthma exacerbations. Leukotriene modifiers are equally effective as asthma relievers. Leukotriene modifiers are as effective and safe as low dose glucocorticoids in mild to moderate persistent asthma. Anyone that can help with this one? Anyone? Be free to speak. Okay, so let's start with option A. Leukotriene modifiers and glucocorticoids are available in oral, inhaled, and IV formulations. So this one is saying which of the following is true about these drugs. So just this statement is not true because glucocorticoids are given either as in an inhaler, metered dose inhaler, or nebulizer. You can as well give them IV, right? You can as well give them IV, but not oral. Not oral. The leukotriene guys, the leukotrienes. Anyone that can remember the methods of delivery for the leukotrienes, we did mention it. Yes. Okay, it is just oral. That's all. And then B is saying leukotriene modifiers can reduce the severity and frequency of acute asthma exacerbation. This is true. Well, the leukotriene modifiers, these guys, when you give them, they are going to be able to reduce the severity and frequency of the acute asthma attacks. When you're talking about treatment of asthma, you have got controllers, those guys that are aimed at controlling the condition. You also, the controllers are also referred to as the preventers. These are the corticosteroids. They are preventing the disease because they are reducing inflammation. Remember, corticosteroids basically working, preventing inflammation just at the beginning before the condition becomes a sin. And then you have got relievers. Relievers, this is where you have got the rest of the drugs that help in modifying reducing the symptoms. So leukotriene modifiers can help reduce the severity, okay? Because it's part of them, of the rest. Except glucocorticoids, the rest are relievers. C is saying leukotriene modifiers are equally effective as asthma relievers. Leukotriene modifiers, they are not. Leukotriene modifiers are equally effective as asthma relievers. How do we even disqualify this option? Okay, first let's talk about the leukotriene modifiers are as effective and as safe as low dose glucocorticoid. Okay, this one we know it is not. They are not the same. They are actually two different drugs. Anyone that can help me disqualify C. Leukotriene modifiers are equally effective as asthma relievers. Or we just know the best, we've already picked the best. Now we so we when we say as effective as asthma relievers, you have got a lot of asthma relievers, and specifically when you're talking about asthma relievers, you are going to see they are going to mention those guys that are causing bronchodilation. The bronchodilators are the ones that we actually specifically refer to as asthma relievers because in asthma I've got constriction. So those drugs that are going to help to make the lumen big, those are the ones that you are going to refer to like that. The beta guys and the choline guys. If the effect of combination of two drugs is greater than the sum of the individual, the two drugs are exhibiting antagonism, synergism, cross tolerance, potentiation. Anyone that can help? Jane, thank you so much. So synergism is where you combine two drugs like one plus one, it ends up giving you three. So what are you seeing? You add two drugs, their combination is greater than their sum. Potentiation is where you add half plus one, you get two. What does that mean? Here you have got one drug intensifying the action of another drug. Okay. That's why you can see this math doesn't add up. Half plus one is two. So one drug is intensifying another drug. You also have what we call additive effect. That is one plus one is equal to two. When you add two drugs, their effect is equal to the sum of the two. Mrs. Mate has a history of chronic liver disease. Take note, that is the liver disease. She has been taking drug X, which is metabolized and excreted in the liver. The drug has very narrow therapeutic index, meaning it is dangerous. The lab results show a 50% decline in liver and normal kidney function. Which of the following actions would be the best option for the clinician to take? Increase the dose of drug X by 50%, prescribe a different drug that is metabolized by the kidney, reduce the dose of the drug X by 50%, maintain the dose of drug X. Which one can we pick? The drug is metabolized in the liver, but this person has got liver disease. And then coming to find out there is 50% reduction in liver disease. Daughter came into the clinic with acute exacerbation of asthma, acute attack. The daughter has mild severity and the mother has moderate severity of acute symptoms. Which statement best describes how each patient will be managed to relieve the asthma attack? Initiating a short acting inhaled beta agonist in both patients. Initiating short acting inhaled beta 2 agonist in the daughter and long acting in the mother. Initiating inhaled glucocorticoid in the daughter and the short acting in the mother. Initiating long acting in the daughter and short acting in the mother. And for this one, so both the mother and the daughter have got acute attack of asthma. The daughter, the condition is mild. The mother, the condition is moderately severe. So how are you going to treat them using beta blockers? Should you initiate the same treatment, short acting inhaled, or initiate short acting inhaled in the daughter and long acting inhaled in the mother, or initiate inhaled glucocorticoid in the daughter and short acting beta 2 agonist in the mother, or initiate long acting inhaled beta 2 agonist in the daughter and short acting inhaled in the mother. Any thought? Why would you go with a doc? Any thought? Thank you so much. So that is it. It doesn't matter whether the condition is severe, it's mild, moderate, start always with a short acting. Mr. Banda has a history of chronic kidney and liver disease. He has been taking drug A, which is metabolized and excreted in the lung. The last lab results show 50% decline in liver and kidney function. So the following actions best indicate what the clinician would do. Prescribe a different drug that is metabolized by the liver or kidney. Reduce the dose of drug A by 50%. Increase the dose of drug A by 50%. Maintain the dose of drug A. Anyone that can help with this one? Maintain the dose. Why would you go for D? Okay, reducing the dose. Thank you so much for that. Is there anyone that wants to give it a try also? Okay, so what the doc was saying is correct. This drug is metabolized in the lungs. So whether the kidney and the liver is not functional, it doesn't affect the concentration of the drug in the body because the lungs where the drug is metabolized are fine. So you maintain the dose, okay, because it's not affecting metabolism at any cost. So it means that it's not disturbing the concentration of the drug in the blood. The concentration is fine. So this 50% decline in liver function, the liver itself is dead. So you have to start now looking for ways to treat the liver. Otherwise, with a drug, continue treating the condition you are treating. Okay. 28. Are we fine on that one? regarding the efficacy and potency of a drug, all are true except ED50 of the drug corresponds to the efficacy. Drug that produce similar pharmacological effects can have different levels of efficacy. In a clinical setup, efficacy is more important than potency. In a log dose response curve, the height of the curve corresponds to the efficacy. Anyone that can help with this one? Which one is not true? All right, thank you so much. So here we have got a dose response curve. Say you have got drug A like that. This is drug A, this is drug B. So you can see these two drugs are producing 50% of the effect, 50% of the effect. For this one, let's say the concentration is 20 milligrams, sorry. Grams is too big. And then let's say this one, the concentration is 40. So I can say they are producing the same effect. But then for drug B, for it to produce the same effect that drug A is producing, you need more dosage. So drug A needs only a little of the dosage. So this guy is more potent. So potency is the amount of drug that you need for 50% of therapeutic effect to be attained. And the more on the left the drug is on the dose response curve, the more potent it is. You can as well compare two different drugs. You have got this drug. So when you're talking about potency, you use the ED50. You can see these two drugs, drug A, drug B. These drugs are showing us effect. Let's say this one, that's the maximum effect that we want. That's 100% of the effect we want. Let's say this one, this is 50% of the effect that we want. So drug B, because it is producing the maximum effect that we want, it is more efficacious. So efficacy is the maximum response produced by a drug. Doesn't matter the concentration at which you've produced the maximum effect. And efficacy clinically is important. Even if you give a lot of drug, as long as you've reached to the maximum of what you want, give, because it will cure the patient, other than you just giving a small drug simply because it's potent but it's not reaching the maximum that you want. So when you are talking about efficacy, you don't use if ED50, the effective median dose. You are not using the effective median dose. Instead, what are you using? You are using the maximum that the graph is going. So the effective median dose, you use it for potency. Okay. So now we can answer the question, isn't it? Which one is not true about the efficacy and potency of a drug from the options here? Anyone? D. In a log dose response curve, the height of the curve corresponds with the efficacy. Is that not true? So we want what is false. S- So this one is true. Let's look at C. In a clinical setup, efficacy is more important than potency. Is that true? Yes, it's true. How about B? Drugs that produce similar pharmacological effects can have different levels of efficacy. Like you can see, drugs that produce similar pharmacological effects. Let's say, for example, these drugs are all working on heart failure. Can they have different levels of efficacy? Like here, one is 50%, one is 100%. Is that true? It's also true. ED50 of the drug corresponds to the efficacy. Is that true? It's false. So That's the answer there. An 11-year-old boy has mild persistent asthma on short and long acting beta 2 agonists. Which controller would you add to his treatment and why? Remember, this boy has mild persistent asthma on short and long beta 2 agonist. A. Leukotriene modifier have better side effect profile even in a child, unlike inhaled glucocorticoids which may cause stunted growth. B. Low dose inhaled glucocorticoids or leukotriene modifiers, whichever is available because they have the same efficacy and safety profile. C. Low dose inhaled glucocorticoids have better side effect profile even in a child. C. Leukotriene modifier because they are all oral formulations. Anyone that can help? I didn't mention this, but one thing that we need to know is that for the glucocorticoids, they have got few side effects. Remember, I said the glucocorticoids; these are the guys that use for prophylaxis or for some conditions like the acute attacks. You can use them at the beginning for those which are real quick. Besides you using them for prophylaxis, you can as well use for that. And the goodness is that you can use them in children. That's for the glucocorticoids. Okay. So which one can we pick as the answer? Anyone? C. Thank you so much. So please just note that glucocorticoids don't cause any bronchodilation. 30. Mr. Walia has a history of chronic kidney disease. Please take note. There is chronic kidney disease. He has been taking drug Z, which is metabolized and excreted by the kidney. The latest lab results show that the kidney function is only mildly impaired. Take note, it's not fully, it's mildly. The drug has a wide therapeutic window. This is important. And is the only, and that's also important, available and affordable. Which of the following actions would be the best option for the clinician to take? Reduce the dose of drug Z by 50%, increase the dose of drug Z by 50%, maintain the dose, prescribe a different drug that is metabolized by the liver. Anyone that can help for this one? Thank you so much. Is there anyone that wants to explain why? Why are we maintaining the dose if we have got mild impairment of the liver here? Sorry, of the kidney, and this drug is also metabolizing the kidney. Why are we maintaining the dose? Remember for that other scenario, we are metabolizing the drug in the liver. The problem was in the kidney, so we maintain the dose. But here we are metabolizing the drug in the kidney, and then the same kidney is mildly impaired. Yes, please. Okay, I'll take that one. Any other suggestion? Okay, so the difference between the two scenarios is that the other one that we read. Yes, doc, you can go on, please. Thank you so much. That's the important thing. So this drug has got a wide therapeutic window, and the kidney is not fully unfunctional. So because of the wide therapeutic window, it means that the drug can still be in blood for a long time and then you are not reaching toxic doses. But even so, the kidney, since it's just mildly impaired, it can to some extent still help in excretion of the drug, even if it's little of it. So you're excreting little at the same time, even when you have got at least a lot in the blood, it is still not reaching toxic doses because it has got a wide therapeutic window. So that's why we're going to still maintain the dose. Okay. Number 31. Inhaled glucocorticoids are the standard treatment for mild to severe persistent asthma. Which of the following answers best describe their role in asthma management? Remember, it's the inhaled glucocorticoids. Glucocorticoids control asthma symptoms by reducing immune mediators and increasing sensitivity to beta 2 agonists. Systemic glucocorticoids are best for children who cannot use the inhaler correctly. C. Glucocorticoids relax bronchial smooth muscles, relieving the bronchoconstriction during an acute exacerbation. IV glucocorticoids are ideal in emergency and chronic poorly controlled asthma. Anyone that can help with this one? Yes. All right. Thank you so much. So we can now pick the best answer because most of those things we did mention them somehow. So the glucocorticoids control asthma symptoms by reducing immune mediators and increasing sensitivity. This is correct. Glucocorticoids, remember we said that they are the guys that we call them preventers or controllers. They actually reduce the immune mediators because you're preventing inflammation. They also increase the sensitivity of beta 2 agonists. If you give like your short acting or your long acting beta 2 agonists, they are going to be more sensitive. That's true. For B, systemic glucocorticoids are best for children who cannot use the inhaler correctly. Now, this statement is false because it's not systemic. For systemic drugs, these are the ones where you are like injecting the drug IV. Okay, like it goes through the entire system. For those who can't use the inhaler correctly, you are going to use uh, the same inhaler, but then there is something that you put at the beginning. We are going to see another question that is going to help them to be able to push the drug, but not a systemic one because systemic you don't use inhalers. Systemic is going through the entire system. Inhalers is local, it's just going to the respiratory system. And then for C, glucocorticoids relax bronchial smooth muscles, relieving the bronchoconstriction. We just said that it has got no effect on that, on the constriction part. There is no relaxation that is playing in smooth muscle, the glucocorticoids. Its work is because of A, just sensitivity increase and also immune system, reducing the immune mediator. And what it does is that if you reduce the immune mediators, the effect of that is that there is not going to be any sensitization of the mast cells. There will be no release of histamine and there will be no constriction. Not that themselves they are going to do anything on the smooth muscles. And then D, IV glucocorticoids are ideal in emergency and chronic poorly controlled asthma. Now, it's not the IV guys. In emergency situations, what you use mostly is actually the ones that you are inhaling, not the IV. Those guys are not ideal in emergency and chronic poorly controlled asthma. What is the primary mechanism of action of indirect acting sympathomimetics? Remember, let me talk about acetylcholine so that This is not acetylcholine. This is about the adrenaline. For the drugs that work like acetylcholine, which are the parasympathomimetics, you have got the direct acting and the indirect acting. So for the direct acting, these guys are going to go and attach to the receptor where acetylcholine attaches. For the indirect acting, they specifically work on the enzyme that is supposed to be breaking down the acetylcholine. Like for example, acetylcholine esterase inhibitors, even those that to prevent the reuptake, because these are indirect. You are just preventing. It's not like you are given a drug that is acting on the receptor, but it's preventing the destruction of the neurotransmitter. Those are the indirect acting. And so this question is asking for the indirect acting sympathomimetics. A, direct activation of adrenergic receptors. B, indirect inhibition of norepinephrine reuptake. C, activation of dopamine receptors. D, inhibition of monoamine oxidase. Anyone that can help with this one now? B, thank you so much. It's reuptake. 33. Mrs. White has a history of chronic kidney disease. He has been taking drug Z, which is metabolized and excreted in the kidney. Take note of that. And she has chronic kidney disease. The latest lab results show the kidney function is only mildly impaired. The drug has a this is narrow therapeutic window and is the only readily available and affordable for the condition. Which of the following actions would be the best? Increase the dose of the drug Z by 50%, reduce the dose of the drug by 50%, prescribe a different drug from different drug Z, but the patient may not have access, maintain the dose of the drug Z and check serum drug levels. Which one would we pick? Anyone? It's D. That's the correct one. Okay. You are remember here they have got the disease of the kidney, and that's where the drug is metabolized. But then the kidney is only mildly impaired. And another thing is that there is a narrow therapeutic window. It's narrow, but the kidney is not fully dead. So what you do is you maintain the drug, but then go and check the serum level. You'll be checking the serum levels to see if you have reached toxicity, so that you can reduce the dose. Okay. 34. Which class of drugs commonly used as first-line therapy for management of symptoms associated with the pheochromocytoma? Now, pheochromocytoma, this is a tumor of the adrenal gland where there is overproduction of the hormones from the adrenal gland, things like the noradrenaline, there is overproduction of those. So you want a drug that is basically going to go to the noradrenal of to the adrenal gland. Salbutamol beta 2, epinephrine alpha and beta adrenergic agonists, phenoxybenzamine alpha adrenergic, methyl-dopa alpha 2. Anyone that can help? Why have you picked this one, Doc? Okay, so the adrenal gland has got this alpha 1 receptors. So we're giving a drug that is specifically working for that. Because adrenergic nervous system, if it is stimulated the parasympathetic, you are going to be producing. Remember, the sympathetic nervous system is fight or flight, and one neurotransmitter for that is cortisol. So also produced from the adrenal gland, which is the stress hormone. So expecting that when someone is stressed, cortisol should be produced, and that is sympathetic. Specifically, that is alpha 1. So therefore, if you want to stop the production of that, you need to inhibit. That's why we're using alpha 1 antagonist. What is the primary pharmacological effect of sympathomimetic agents that selectively stimulate beta 1? Please, this is beta 1. Vasoconstriction, bronchodilation, decreased heart rate, positive inotropic and chronotropic effects of the heart. Anyone that can help us? What is the primary effect of beta 1 adrenergic receptor drugs? Yes, please. Thank you so much. And remember specifically, these are stimulating. So when you stimulate the heart, there is contraction, increase the heart rate, so that is positive inotropic and chronotropic. But if these were antagonist, it would be B because you're going to be reducing those things. Okay. 36. Which of the following factors are physiologically factors that commonly cause variation in a drug response between individuals and in the same individual? Sex, idiosyncratic reaction, body weight, disease state. Anyone that can help us with this one? It's the body weight. Remember, we said for the factors that modify drug effect, specifically for the, and here we're talking about physiological things. Sex is physiological, idiosyncratic reaction is physiological, body weight is physiological, but the disease state is not physiological. But since we are talking about between individual and same individual, this is basically body weight because sex is going to be just within the same individual. Which sympatholytic medication is commonly used to treat benign prostate hyperplasia by relaxing smooth muscle in the prostate? So the thing is this. Here is the male. So that is going to be the urethra there connecting to the blood and such. So I've got the prostate gland at this point. So le- if the prostate gland is become big, it is going to compress on the bladder so someone can't urinate. But then another thing is going to, there is no urination there if someone has got benign prostate hyperplasia. So how can you help? You want to give a drug that is going to come and help by causing the urethra to dilate. Okay, to dilate. And you know that the sympathetic nervous system you are running, you can't go to the toilet. So you want to give a parasympathetic drug or a drug that is inhibiting the sympathetic, that is a sympatholytic, the blockers, the alpha blockers and the beta blockers. So which one can you give here? So you want to find a drug that has got specific receptors on your urinary, your urethra. Yes. Doxazone, doxazosin alpha 1, tamsulosin alpha blocker, labetalol alpha and beta blocker, carvedilol beta and alpha blocker. Which one can we pick? Okay, so on this guy we have got alpha receptor, so we are going to pick the alpha receptor blocker, which is the tamsulosin, or as second messengers except IP3, CAMP, DAG, guanylyl cyclase. Anyone that can help? Which one is not a second messenger? Yes, remember, guanylyl cyclase will just help in converting CTP to CGMP. It's not a second messenger itself. IP3 is cyclic MP and DAG. 39. The antidote action of sodium nitrate in cyanide poisoning is based on chemical antagonism, non-competitive antagonism, physiological antagonism, physical antagonism. Anyone that can help for this one? The antidote action of sodium nitrite in cyanide poisoning. Remember, someone has been poisoned with cyanide. Cyanide is an ion, it's a chemical. And then you are using another chemical to displace the cyanide. So what kind of antagonism is that? It's chemical. Okay. Physiological antagonism is where you give a certain drug that will produce a different effect to the one that caused the effect. Let's say, for example, you gave someone a drug, and then maybe they had a fast heart rate. In physiological antagonism, you give them another drug that will slow the heart rate. That's physiological. Magnesium sulfate is an over-the-counter oral laxative. When administered IV, magnesium sulfate treats convulsions in preeclampsia, which is pregnancy-induced hypertension, with a narrow therapeutic window. Which of the following reasons may explain the difference in drug function and safety in the same drug? Oral formulation of the drug is absorbed from the gut, but it has a different mechanism of action. Remember, this drug is administered IV, but the same drug, so magnesium sulfate is over the counter laxative. When administered IV, magnesium sulfate treats convulsions in preeclampsia with narrow therapeutic window. Which of the following reasons may explain the difference in drug function? The oral formulation of the drug is absorbed from the gut, but it has a different mechanism of action at each target site in the body. The drug's distribution is affected due to altered plasma protein binding. The side effects of the drug are idiosyncratic because they are rare and unpredictable. Oral drug is not well absorbed from the gut, making it act locally without therapeutic or adverse effects on other systems. Anyone that can help with this one? Pardon? Okay, we can pick D. Look at this. The oral drug is not well absorbed, making it act locally. So if something is not well absorbed, it will still remain in that place where it's not absorbed. So it will act locally. And because it has not gone far, it will not produce these convulsions that we can see with the IV, because IV is also reaching to the central nervous system. But you are simply treating preeclampsia. Okay. We are remaining with the three MCQs. Which of the following statement is true about managing asthma using this group of drugs? Long-acting beta-2 agonists are relievers and controllers because they can lower immune mediators to the same degree as corticosteroids. A long-acting B2 agonist can be added to short-acting beta-2 agonists because they produce longer-lasting bronchodilation. See, long-acting beta-2 agonists can substitute short-acting beta-2 agonists, relieve acute asthma exacerbation because they have an early onset and longer duration of action. D. Long-acting beta-2 agonists require less frequent dosing in a day than short-acting beta-2 agonists because they have a longer duration of action, therefore they are unlikely to develop tolerance. Anyone that can help with that one? Look at A. Long-acting beta-2 are relievers. That's true. And controllers. Now, these guys are not controllers. Okay? The controllers are the corticosteroids, which prevent inflammation. So that's not true. B. Long-acting beta-2 agonists can be added to short-acting because they produce longer-lasting bronchodilation. This is true. Long-acting beta-2 agonists can substitute short-acting to relieve acutes. You can't substitute them in acute exacerbations, and they have got an early onset of action. They don't even have that. Long beta-2 require less frequent dosing in a day than short-acting because they have a longer duration of action. Therefore, they are unlikely to develop tolerance. So look at what makes D wrong. Long-acting beta-2 require less frequent dosing in a day than short-acting beta-2 agonists because they have got a longer duration of action. You don't even take these guys like in a day. What you do is the comparison here is wrong first, because for the beta-2 guys, the short-acting, you are giving them when the acute attacks are there. It's not in a day. 42. An asthmatic patient in Chama village. By the way, have you heard of this one? And I'll mention it at the end. Let's first. An asthmatic patient in Chama. Let me just mention it anyway. There's what is known as a status asthmaticus. If you go and do the drugs that treat epilepsy, you also hear of status epilepticus. This is like the worst case scenario in asthma. Someone can't breathe. Okay, an asthmatic patient in Chama village cannot find short and long acting beta 2 agonist with a glucocorticoid inhaler he was using in Lusaka. He has moderate persistent asthma. Which alternative drug with multiple formulations, please take note of multiple formulations, can he have similar efficacy to his regular medication? Because he can't take the short and long acting beta 2 agonists because he doesn't have his inhaler with a glucocorticoid. So we want something that has got multiple formulations. A. Methylxanthine theophylline causes bronchodilation but has the same safety profile as B2. B. Ipratropium bromide acetylcholine masculine antagonist is a reliable reliever in all patients. C. Methylxanthine theophylline causes bronchodilation and offers long-term control. D. Continue only on glucocorticoid because a patient will never have acute asthma exacerbation on a potent suppressor of inflammatory mediator. Statement is it true of the dose log dose response curve. It is a rectangular hyperbola. It can help in discriminating between competitive and non-competitive antagonism. It facilitates the comparison of different agonists. It is almost linear except at the end. Anyone that can help with this one? Which one of these is not true? For those that attended or watched the previous class that we discussed, we already answered this question. So the answer is it is a rectangular hyperbola. We said that hyperbola is a graph that looks like this. But we know that for a dose response curve, the graph goes like that. So that's not an hyperbola. Which of the following symptoms is commonly associated with a cheesy reaction in patients on monoamine oxidase inhibitors who consume tyramine-rich foods? Hypotension, bradycardia, hypoglycemia, hypertension. Anyone who can help with this one? The cheesy reaction. What is the problem there? Are people sleeping? We end here. We are just from doing neurosciences, and we did discuss about MAO inhibitors and how they interact with SSRIs, how the SSRIs will be able to interact with other drugs. So what is the tyramine rich foods, the cheesy reaction? What condition is associated with it? It's hypertension. So that's a hypertensive crisis. Thank you so much. We can now, should we go on and do the matching questions? They are easy since we've done everything. Right? Should we go on? So the faster we answer, because there are few questions, the faster we answer, the quicker. The following statement refers to the action of norepinephrine action in the sympathetic nervous system. Which option correctly matches the statement? Regulation of adrenergic neurotransmitter is achieved by, and norepinephrine action terminated primarily by active transport into the cytoplasm of a presynaptic neuron is called. So let's start with two. Norepinephrine action terminated primarily by active transport into the cytoplasm of presynaptic neuron is called. So know that norepinephrine, after it has done its work, is going to be removed from the presynaptic cell, being taken back here. What is that code? Is it uptake 1, uptake 2, or alpha 2 adrenergic? Uptake 1, thank you. So this is B. Uptake 2, what happens in uptake 2? We have got a vesicle inside, so we'll get this guy and take it there. Regulation of adrenergic neurotransmitter is achieved by. How about that one? What would be the answer? Yes, regulation of adrenergic neurotransmitter is achieved by alpha 2 adrenergic. Match the description of type of drug and to the type of drug antagonism. So A, cyanide poisoning. Cyanide poison is irreversibly block. Cyanide poisoning irreversibly blocks adenosine triphosphate production during cellular respiration. What type of antagonism is that? Competitive, non-competitive, physiological, or chemical? It's what? It's chemical. That's the one you choose. Chemical. Cyanide poisoning irreversibly blocks adenosine triphosphate during cellular respiration. Mostly, okay, if you If you hear of this kind of reversible and irreversible, you have got, this is your receptor. This is the allosteric site. It can bind here. If it strongly binds, that's going to be irreversible. If it weakly binds, it's reversible, but you still have the active site there. So what type of antagonism is that? It's non-competitive. So that is going to be D. It's non-competitive. And then it's 2, deferoxamine binds to iron as an antidote for iron poisoning. What type of antagonism is that? That's chemical, isn't it? Thank you. And then calcium supplement prevents the absorption of tetracycline from gut. What type of antagonism is that? Okay. Calcium supplement prevents absorption of tetracycline from the gut. So you can see these are two different guys. You have got calcium. When you give someone calcium, it is preventing, you have got, tetracyclines, let's say this is their receptor, they'll bind to another receptor. Calcium doesn't bind to the same receptor for the tetracycline, meaning that it's going to have its own binding point, and then when it binds there, it affects the binding of that guy. So which one is that going to be? It's also non-competitive. So there's another non-competitive that we picked, isn't it? Which one was that? That was A. Now let's look at A again. Cyanide poison is irreversibly blocks adenosine. Now this is specifically, this is an ion. This is a chemical, and it's preventing ATP is also a chemical. Please just make the correction there. And then, is that even making sense? Because we've mixed up something there. Sh- should we go back to that just to correct it? Let me go back to that. So on A, cyanide poisoning irreversibly blocks. So that one is still fine because of the irreversibly blocks. That's going to be non-competitive. And then deferoxamine binds to an antidote for iron poison. That's fine. Calcium supplement. So this is where we are. So which one are we saying we are going to settle for? A chemical also. So we have got two chemical antagonisms there. Okay. And then the next one, that's D. 4. Magnesium sulfate controls convulsions, causing muscle relaxation by displacing calcium at the target receptor. There is displacement there. What kind of antagonism is that? That's C, competitive. And then 5, adrenaline when reversing the effect of histamine mediated anaphylactic shock. What type of antagonism is that? Adrenaline when remember histamine is producing one effect. Adrenaline is going to do the direct opposite of histamine. So what antagonism is that? Pardon? It's physiological, thank you. Match the description of terms related to autocoids and their pharmacological action. Generation of the group of drugs used to treat allergies but used to treat insomnia, motion sickness, and vomiting. Just think of it. Remember when you're talking about the tricyclic antidepressants or just the drugs used in depressive disorders or these other disorders. The first generation normally is non-selective to say, like it works at a lot of places. Let's say if this drug is targeting the brain to help in depression, it is going to other receptors. But then the other generations, as you go on, they are becoming more specific, and so they are going to reduce on the side effect. Okay, but for this one generation of group of drugs used to treat allergy, but when you are treating allergy, they are also used for insomnia, motion sickness, vomiting due to excess H3 receptor. So which ones do you think are those? Antihistamines, NSAIDs, calcitonin, serotonin, first, second generation antihistamines. First generation, thank you. Neuropeptides involved in calcium metabolism are prescribed for bone health in osteoporosis and Paget's disease. Which one is prescribed? Which one? Calcitonin, yes. Remember, when you have got too much high calcium, calcitonin will be produced. When you have got low calcium, parathyroid hormone is produced, but you can also give it as a drug. An autocoid targeted. An autocoid is just a drug that works on a nearby receptor. That's the meaning of autocoid. So, an autocoid targeted in treating depression, obsessive compulsive disorder, and obesity. Which one is that? We can just look at depression. We've been talking about this for long now. Thank you so much, serotonin. Generation of the group of drugs used to treat allergies with fewer side effects due to less CNS penetration. How about this one? Remember, it's the same like one, but this one has got fewer side effects. So, what do you think? Thank you. The second generation antihistamines. And then, acronym for the group of drugs used to treat inflammatory conditions and the acute pain that also affects the intrinsic production of prostaglandins in the stomach. Which ones are those? It's the NSAIDs. Thank you. Remember NSAIDs, they can inhibit the COX enzyme, and so they are going to help in pain, inflammation. But they also do it in the stomach, and so they will result in that acid production. Match the description of the type of interaction. Attach. So here we have got also, we're talking about the receptors, also competitive, non-competitive, chemical, physiological. So number one, attach to the same or different receptor as a drug. The effect is insurmountable by increasing drug concentration with an irreversible effect. Remember, if you just hear anything with irreversible, what do you think that is? Competitive, non-competitive, chemical, physiological? Non-competitive, thank you. And then two, attaches to different receptor from the drug, causing an independent effect opposite to the drug. So for opposite, remember this is opposite. If there was an increase in BP, it decrease. Which one would that be? So that's physiological, right? Every time there's opposite action, that's physiological. And then three, does not attach to any receptor, combine with a drug or poison, and the complex is formed. What is that? Chemical. Attaches to the same receptor as the drug, and the effect is surmountable by increasing drug concentration, hence reversible. That's competitive. We want to match the description of the type factor affecting drug response with the best. Chemicals in the food ingested can interfere with drug pharmacology. Chemicals in the food. Is that pharmacokinetic variation, food drug interaction, disease drug interaction, placebo effect, or pharmacodynamic variation? Chemicals in the food. Can interfere with drug pharmacology. Food drug, thank you. And then two, different concentrations of the drug reach the target. Different concentrations. Pharmacokinetics, thank you. Different responses to the same drug concentration at the target site. Pharmacodynamics about response receptors. Okay, and then three, is it four? Presence of certain diseases can influence drug response. Thank you so much. Disease drug interaction. And then number five, drug response in suggestible patient due to their psychology. Placebo, thank you. You respond to a drug simply because you believe you'll have the doctor that gave you. So you end up getting well. Match the description of terms related to autocoid with the best answer. An autocoid vasoconstrictor found in platelets, GIT mucosa, and neurotransmitter in the brain. Which one is that? Calcitonin, cytokine, serotonin, histamine, eicosanoid. Eicosanoid. Which one? Which one is an autocoid vasoconstrictor found in platelets? We've described asthma, so we can be able to tell. And it's a neurotransmitter in the brain. It's also a neurotransmitter in the brain. That's a statement. Or for this, which neurotransmitter have we discussed in neurophysiology in neuropharmacology? Serotonin. So that's the answer there. And then number two, autocoid released by mast cells involved in allergy. Which one? Histamines. Number three, collective term used to describe prostaglandins and leukotrienes. Eicosanoid. Thank you. Very short acting substance. Cells produced to act on the cell or neighboring cells. A cytokine. Neuropeptide involved in calcium metabolism are prescribed for bone health, osteoporosis, and Paget's disease. Calcitonin. Thank you. Any circulating substance in the blood that deplete lean body mass in critical illness. Okay, when the answer is there, it's an autocoid. Any circulating substance in the body that depletes lean body mass. Lean body mass is fat-free mass. Like that part of your body that doesn't have fat, like your muscles, that's lean body mass. It will be depleted by the autocoid. Match the following causes with the explanation for differences in individual variation. The exact cause is unknown, unexpected, and unpredictable, and it is not dose dependent. Is it extremes of age, larger body mass, psychology, pregnancy, or idiosyncratic reaction? Thank you so much, idiosyncratic, isn't it? And then the relationship between the health care provider and the patient's personality may affect drug and response. What do we call that? Psychological. Drug dilution and increased drug metabolism and excretion. What factor is responsible for a different response to a drug because there's going to be drug dilution and increased drug metabolism? Is it the age size? Huh? Thank you so much. Organ responsible for drug metabolism may be immature or decline in function. It's the age. Thank you so much. Change in psychophysiology that include increased BP, blood volume, drug safety may require a change of drug or dose. The pregnancy, that is physiological. Three more questions to go. Match the following administration of beta 2 agonist and glucocorticoid with the patient indication and state. A. A woman with severe persistent asthma, but not in an acute exacerbation. So this patient has got asthma, but it's not acute. So would you prefer to give something that is confined to a system or something that can be systemic? Okay, thank you so much. Anyone with another thought? Okay, because this patient has got severe persistent asthma, but it's not an acute attack. You can give them orally. It's not an acute attack. They still have time for it to be absorbed, right? So that will be systemic oral. So, pardon me here. I was also supposed to put systemic IV. Okay. Okay. All right. So I was saying for a severe case that's persistent but not acute, it's not an acute attack. You can use something that is oral and it will go systemic because remember this is not too like it's not an acute attack. It has not happened and then starts that someone needs really something to help them. See something maybe they live with. So you can give them orally, systemic orally, right? A- And then two, patient in status asthmaticus in need of ventilatory support. Status asthmaticus, this is like the worst case scenario where someone is failing to breathe, they've had this attack and then like it's bad. That's a status asthmaticus. The worst case scenario, you really need to help them. You need to support them to breathe. So, by what method do you think we can give them the the antiasthmatic drug? So you don't even have time for you to start giving them nebulizer because they'll not even use it. You need to put the drug in the veins. So that will be IV. Are we okay there? Is that okay? And then number three, a patient with severe asthma attack and high respiratory rate but not in respiratory failure. Which method do you think we can give them? There is severe asthma attack, high respiratory rate, but there is no failure of the respiratory system. So you can give using a nebulizer. A child who has mild asthma but cannot use the metered dose. I even mentioned this accurately. Which one can you use? I said there's something that you put to the metered dose. The same metered dose inhaler, but there's something you put there. So which one do you think is the best option for four? So it's with a Spencer, right? That's the one you use in someone like a child. They don't know how to use this thing. And then five, a man with mild persistent asthma and can follow instructions. So if they can follow instructions, then you can now tell them how to use the inhaler. So they'll be able to use that guy well. Number nine, match the the questions with the other guy. So desensitization of the drug. Is that taphylaxis, tissue tolerance, cross tolerance, physiological tolerance, acquired tolerance, or natural tolerance? Desensitization of the drug. Actually, to finish, desensitization of the drug due to compensatory mechanisms by the body to reverse the effects of the drug, e.g., beta 2 receptor blocker and catecholamines. Remember, desensitization of the drug occurs due to compensatory mechanism by the body to reverse the effect. So what do you think that is? Pardon? Mm, remember, is to reverse. Like just like we gave an example. If someone has got high blood pressure, we give something that is to lower their blood pressure. It's physiological. Thank you. And then number two, the occurrence of desensitization to the drug occurs rapidly, usually hours to days. Tachyphylaxis. Thank you so much. Three, desensitization to the drug is present without previous exposure to the drug, but after exposure to other drugs affecting that system. Okay, thank you so much. Acquired tolerance. So remember this one, there is desensitization to the drug in present without previous exposure. There is no previous exposure, but after exposure to other. So there is other drugs. So you have got two different drugs. Because you have been desensitized to one, you end up getting desensitized to the other one. So that is cross. Remember two things, cross tolerance. And then number four, desensitization to the drug occurs because a higher dose at the target site is required to get the same response. How about that one? Desensitization to the drug occurs before because a higher dose at the target site is required to get the same response as before. Okay, so that is known as tissue tolerance, where there is desensitization to the drug because a higher dose at the target site is required to get the same response as before. So initially, let's say you are getting 70% response with only 40 milligrams of the drug. But for you to get this same 70%, you now need, let's say, 80 milligrams at the same receptor. That is it, tissue tolerance. It's the tissue. Okay. It's the same site. And then five, desensitization to the drug is present without previous exposure to the drug or other drugs affecting that system. How about that one? Remember, it's without previous. That's natural. And then the last one, desensitization to the drug occurs after repeated or continuous use of the drug. Repeated or continuous use. That's acquired. Thank you. Second from last question. Following questions refer to NSAIDs and their mechanism of action. Irreversible inhibitor of COX. Which one? Meloxicam, aspirin, COX-1 inhibitor, selective COX-2 inhibitor, paracetamol. Irreversible inhibitor of COX. Which one can we pick? Okay, so aspirin is irreversible, thank you. Most likely to cause MI, myocardial infarction. Which one of these is most likely to cause myocardial infarction? Me- melo- Meloxicam, aspirin, COX-1, selective COX-2, paracetam. Okay, so selective COX-2 inhibitors are more likely to cause MI. Three, has use in prophylaxis of MI. Which one can you use for prophylaxis of myocardial infarction? So the same aspirin, yes, is going to be used for prophylaxis. COX-3 inhibitor without anti-inflammatory effect. Which one? Paracetamol, yes. Has the lowest incidence of GIT adverse effects. So meloxicam is a very good guy. It doesn't have GI side effects. And then the last one here, the following pharmacokinetic parameters are used in the calculations to devise those formulations. So number one, determine the average concentration achieved if a drug is administered at regular interval. Remember, the average concentration achieved if a drug is achieved by regular interval is that volume of distribution, clearance, or elimination half-life. Or we can start with to give an understanding of the time taken for the drug to be completely removed from the body. What is that? The time taken for the drug to be completely removed from the body is elimination half-life. How about D? They determine the loading dose of a drug in treatment. It's a VD, right? Volume of distribution. And then determine the average. Okay, so for which one is that? All right, I've taken something else. Okay, for two, gives understanding of the time taken for drug to be completely removed from the body. So this is the one we said this, isn't it? And then for A, determine the average concentration achieved if a drug is administered at regular intervals. That is clearance, because clearance is talking about how much drug you are removing from the body. So that is B. And then for D, determine the loading dose of a drug in treatment. That is volume of distribution. The loading dose, how much is going to the tissue. That's it. That. And this is where this paper ends. That is 2024 test 1 pharmacology finished. So continue with other papers. We'll do test 2 next time.